So have you ever noticed that when you go to coach squats or deadlifts, you have prerequisites, you have strategies, you have regressions, progressions, but then when you go to coach a plank, you simply tell your patient to go down in a plank position and hold for 30 seconds. Well, hopefully you see that there's a disconnect here, and I want you to remember that chances are that you're prescribing that plank to help your patient get out of pain. So if that's the case, your patient needs a checklist and strategies in case pain actually does present itself. And when that pain does present itself, they then have the necessary steps to make sure that they're staying out of pain and they're moving in the right direction. So in this video, we are going to discuss 5 simple strategies so that you can coach a perfect plank and your patient learns right versus wrong. Before you can use those coaching cues, we first need to make sure that we understand the rib cage. Now, the infrasternal angle is a topic that we go into a great amount of detail in the Performance Redefined course. So if that is something that you're interested in learning more about, I would encourage you to check that out. However, for this video, we will give a very brief outline as to the ISA and how it relates to planks. So the ISA is the infrasternal angle, or the angle that the rib cage makes with the sternum or the xiphoid process. And all our patients are biased towards either a wide or a narrow. So a wide infrasternal angle is typically greater than 90 or 100 degrees as far as this angle. And how that is created is from anterior to posterior compression. So think about musculature on the anterior aspect and the posterior aspect compressing. What happens there is we get compression at the pump handle, right? And then that compression expands the bucket handle. So we'll have expansion here. Now, as it relates to planks, if you think about a plank, the traditional position, how it's executed, actually promotes the same amount of compression and expansion. So a lot of times for wide ISAs, a plank is not necessarily the best starting point. Conversely, what these types of individuals will respond well to is a side plank. And I have a video that goes over how to coach that perfect side plank that I'll reference in the description below. So that's the wide. Now let's talk about the narrow. The narrow is just the opposite. The narrow is going to have compression laterally, and they're going to have more of their expansion anterior to posterior. So as it relates to our traditional plank, this actually helps to promote movement variability for these individuals. Why? Because the traditional plank is going to bias exactly what they're not good at, right? The narrows have too much expansion here, too much compression here, and the traditional plank actually promotes compression at the pump handle. So now you understand the wide versus the narrow a little bit better. I want you to really take away the main point that it's not necessarily wrong to do a plank for a wide ISA. However, the key is just being aware of these compression and expansions and the response that the plank is going to have on your specific patient. Now let's jump into the coaching cues. And the thing with the coaching cues is we are trying to use as minimal verbiage as possible. And what this does is really helps clear any sort of confusion piece that your patient may experience during a plank. So step number 1 is head down. Now, for some reason, a lot of us tend to want to look up when we are performing a plank. And the response of looking up actually triggers a lot of extension bias throughout the cervical, the thoracic, and the lumbar spine. Now remember, the plank is an anti-extension exercise. We are trying to avoid extension. So when we go in that head up position, we're actually driving extension throughout a lot of the system. So instead, all you're going to do is cue your patient to have their chin down. And I like to use the reference as I want your neck and your head to be relaxed as if it's a bobblehead doll. So that's one cue. The other thing you can do is tell them to imagine they have a tennis ball under their chin and to not let that tennis ball fall. And that's going to help keep everything relaxed and promote a little bit more of a flexed based position. Step number 2, neutral shoulders. Consciously or subconsciously, patients always go to a clasp or a praying position when they do a plank. The problem with this is that it internally rotates the shoulders while we have most of our weight going through the shoulder, and it usually results in premature fatigue. So instead, a simple fix is grabbing a dumbbell or grabbing something that will have your patient in a shoulder width position and cue them to just keep their arms there as they're performing their plank. Step number 3, chest up. Scapular retraction is a very easy stability point that a lot of our patients tend to find. The problem with this is that they're going to fall into extension as they get into that scapular retracted position. Ultimately, they're also going to experience that premature fatigue that we previously talked about. So an easy way you can fix this is to tell them to drive through their elbows, and when they drive through their elbows, we'll cue them in the term chest up. When they move their chest up towards the ceiling, what we're going to do is then protract the scapula, right? But we're also going to work on increasing the congruency between the scapulothoracic joint. Remember, a lot of our patients live in this extended posture with rib cages that are coming forward and up. So cueing the chest up and driving through those elbows is a great way to help depress the rib cage and bring that back and increase the congruency between the rib cage and the scapula. Step number 4, belly button up. This is a really great cue to help avoid extension and an increase in lumbar lordosis, right? The hands down most common compensation that we see with the plank is that increase in lumbar lordosis or extension through the low back. So an easy way that we can start to cue them out of this is to reference their belly button. Here's what you want to do. You want them to raise their belly button up without moving their hips. And the second that you see this happen, you will see their abs engage and you'll see their facial expression because they'll start to feel their abs. Remember, a really easy principle to remember is that your patient that has an increased lumbar lordosis in standing posture, you will most likely have to have more of an increase in hip flexion during their plank. This will help to bring them back to more of a sense of normal, a normal starting position, so that they can get the most out of their plank. Step number 5, belt buckle. This is a great reinforcement to the previous belly button cue. I want you to tell your patient to imagine that they have a big belt buckle on, and I want that belt buckle to draw towards their chin. So what this is doing is this is promoting a more of a posterior pelvic tilt, helping them get out of that extension through their lumbar spine. If they don't like that cue, another cue you can use is to tuck the tailbone underneath the hips. These two cues work really well. The thing that I really want you to take away from it is make sure we're not going to an extreme amount. A lot of times with the belt buckle cue or tucking the tailbone, a lot of us go to that extreme posterior pelvic tilt. We are trying to live on the edge of kind of a neutral and a slight bias to a posterior pelvic tilt compared to an anterior pelvic tilt. And a bonus, step number 6, is breathe. None of this is valid if your patient can't breathe. I see it all the time, and this may be something that you guys are letting slide. And what happens is a lot of our patients can do these things, but they're holding their breath. They're creating so much intra-abdominal pressure from air that they're not really utilizing the muscles that we're wanting. They're not getting the relative motions of the pelvis that we want. So during each step, see if your patient can breathe. And by the end of it, after these 5 steps, they need to be able to inhale through their nose, exhale through their mouth, and be able to maintain all the prereqs that you just went through. If they can't, start over. If they still struggle, change the position. The next thing you can do is change them to more of a quadruped position. This will take away and give them a little bit more stability so that they can then focus on breathing while moving through the right positions.